Welcome to This Week in Health IT. It's Newsday. My name is Bill Russell, former healthcare CIO for a 16-hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Special thanks to Sirius Healthcare, Health Lyrics, and Worldwide Technology, who are our Newsday show sponsors, for investing in our mission to develop the next generation of health IT leaders. We set a goal for our show, and one of those goals for this year is to grow our YouTube followers. We have about 600 plus followers today on our YouTube channel. Why, you might ask? Because not only do we produce this show in video format, but we also produce 4 short video clips from each show that we do. If you subscribe, you'll be notified when they go live. We produce those clips just for you, the busy health IT professional. So go ahead and check that out. We also launched Today in Health IT, a weekday daily show that is on todayinhealthit.com. We look at one story each day and try to keep it to about 10 minutes or less, so it's really digestible. This is a great way for you to stay current. It's a great way for your team to stay current. In fact, if I were a CIO today, I would have all my staff listening to Today in Health IT so we could discuss it. Agree with the content, disagree with the content. It is still a great way to get the conversation started, so check that out as well. Now, on to today's show. All right, today we are joined by Ed Marx. Ed is a friend of the show, been on many times. Welcome back to the show, Ed.
Thanks, Bill. It's really excited to be with you. I really appreciate the invite.
Yeah, I'm looking forward to it. So you are launching a new podcast. You are competition, which I don't really care about. I'm always about getting the best thinking out there, and you have some great thinking, so I'm looking forward to it. Tell us about the podcast.
Oh man, there's no competition to Bill Russell when it comes to podcasts. So it's different. So it's called Digital Voices. It launches officially next week. We've actually recorded, I think, the first 5 or 6 episodes. We'll just drop weekly. And what it's meant to do is cross all of health and life sciences. So instead of just the payer, instead of just the provider or pharma, we're crossing all of it. So Digital Voices, so includes like chief digital officers and other interesting people of interest from all those different segments, including patients. So actually our very first drop is the digital voice of a patient. And it was quite powerful. So I'm really looking forward to it. And it's really meant to just add to the discussion and try to break down the barriers between payer, provider, payer, pharma, the whole continuum. So that's what it's all about. And hopefully it'll be enjoyable.
Yeah, and we're gonna talk a little bit about that divide and things that exist today. So it should be interesting. So the unifying principle is really around digital, right?
Correct. So, there's the emergence of the chief digital officer, as you've spoken about quite well. And who is the voice right now for the chief digital officer? And you've covered it really well in terms of some CIOs are capable of doing both. In many cases, CDOs have been brought from outside industries and CIOs are reporting to them. And it's really quite an emerging field. So it's really about capturing that field across, again, the health continuum and really creating a forum for them to interact, to talk about issues that cross over all the way into the patient side of things. So that's why Digital Voices and why we created it.
It's interesting, Ed, because in the last 90 days, just the interviews in just the last 90 days, so Tressa Springman now has the CDO role. Jason Joseph at Spectrum has the CDO role. Craig Richardville at SCL has the CDO. So it's a dual role, CIO, CDO role. So the more established CIOs who have been around a while are latching onto it, as well as some others we know that have both the CIO and CDO role.
Some are able to pull it off well and are well trained and kept up with the times and are easily able to operate in both. But unfortunately, it's not the case for the majority. And so that's the other thing we're trying to do with Digital Voices is bring out outside industries. So one of our first guests, again, these pods don't start dropping until next week, but yesterday we had a guest from telecom and how they've digitally transformed their particular telecom company and how it might help healthcare. So there'll be a lot of external guests coming into our digital officers and what have you from other companies. And the hope is that we can all learn from them so that we don't need them to come in and displace us, but we can learn from them and upskill and lead all things digital.
Yeah, one of the podcasts I listen to is the Accenture podcast. And one of the reasons I do that is because their CIO has boldly gone to the cloud to the point where there is nothing but the cloud left at Accenture. And they talk about the agility of that and being able to ramp things up and being able to write applications on top of a well-architected cloud stack. And it's really fascinating. I haven't seen the health system that boldly has said 100% in the cloud yet.
Yeah, it's really tough to do. As you know, just the legacy, the history, the culture, difficult to move with agility and velocity in healthcare. And it's sorely needed, right? It's one of those key tenets that have held us back. Although, as you've pointed out and others, during COVID, remarkable job, remarkable leadership across the board. So that gives me a lot of hope, and I'm really hopeful that that will continue. That it just wasn't a blip in the radar, but that's the new way of operating.
I remember in our cloud journey, I asked the question of like, so can we move PACS into the cloud? And they're like, the operational PACS? I'm like, yeah, can we move that into the cloud? And they're like, no, you can't move that into the cloud. I'm like, okay, here's what I'd like for you to do for me. Tell me why I can't. And they're like, well, it's going to be too slow. I'm like, give me the math. They're like, well, no one's ever done it. I'm like, that's a different argument. No one's ever done it. Give me the math. Let's see if we can do it. And then we eventually did it. And I think to this day, if you walked in and said, can you run PACS in the cloud? Most people would say, oh, you still can. It's too transactional, whatever. I'm like, and if you architect it correctly, you can. You just have to get people to stop saying, it can't be done and start answering the question of why can't it be done? I mean, we can do a lot of things, clearly.
Yeah. And sometimes you just have to allow that person that doesn't have the same confidence level to have the experience. And so one of the things that we did, I'll never forget this and I think it's cool to talk about who it was in the organization, because it's a very positive story, but it was at the Cleveland Clinic. We're number one in the hearts, right? For 27, 28 years in a row, global leader. So there was a lot of skepticism about moving to the cloud. So we got the lead of Cleveland Clinic, cardiovascular surgeon, top of the world, the division lead, to come out to our data center. Okay, so we still had a data center, which I was trying to get rid of and all those things, but at least gain some confidence that we could do some of these PACS and some of these other really intense imaging remotely. So that was like the first step, to take it from the closet next door to the data center. That was a big, bold move before we moved to the cloud, just to show that could be done. Well, I left before he did. So we had an hour to do a tour and to talk about the data center, how it worked. He stayed. He took pictures, selfies. I have selfies with him because he was so excited, because it dawned on him that the data center or the cloud was like the cardiovascular system and how it worked, and how you had a sort of a center, the data, and then you had arteries and how things flowed. And so we just started using that sort of vernacular in our explanation about why it's beneficial, to move to the cloud and how it really works. And you're still connected and there's still blood flowing through. And that was magical experience. And so sometimes you have to let the doubters, sort of the doubting Thomas, touch the wound or see what the cloud is, and kind of have more of an experiential as opposed to philosophical discussion.
Yeah. And that gets us to our first story. And I'm going to share this because I didn't share this with you ahead of time. So this is the Truveta announcement, and this is a post from Rod Hochman, President and CEO of Providence. When Providence established our vision of health for a better world, we knew data was the key to the future of health and medicine. Healthcare providers across the country maintain and protect copious records, serving as the custodians of vital health information. Some of this is obviously, grandiose words to announce a new offering, but here's why I want to talk about it. When de-identified and securely aggregated data at scale can produce valuable insights and have the potential to revolutionize the way to prevent, treat, and cure disease. Toward that end, Providence has been working to build a coalition of the nation's major healthcare providers with the goal of bringing our de-identified data together onto one secure platform. Today, they are excited to announce 14 health systems: Advent Health, Advocate Aurora, Baptist Health in Florida, Northeast Florida, Bon Secours, Mercy, Common Spirit, Hawaii Pacific, Henry Ford Health System, Memorial Hermann, Northwell Health, Novant Health, Providence, Centera Health, Tenet Health, and Trinity Health. So that's no small, that's That's a pretty sizable data set. Truveta is in the early stages. They've hired a person, let's see, Terry Myerson, a former executive vice president of Microsoft, has agreed to lead the charge in his 21 years at Microsoft. He oversaw Windows, Xbox, Surface, and I would say that that's not nearly enough experience. When he gets into healthcare, he's going to realize what he's signed up for, as we all have over the years. As we've seen with COVID-19, data insights cannot come fast enough. They are essential for quickly understanding new viruses and other diseases. And so they're going to bring that together. The time is now for healthcare communities to step up and lead the way. Big tech companies and even foreign entities are vying for access to patient data as healthcare providers. It is one of our highest duties to safeguard the personal health information of our patients entrusted to us. Truveta is our answer to putting those safeguards in place, and we can ensure that privacy is paramount, that health information is protected. It's okay. So, couple things. I wanted to talk about this with someone, and you're here, so this is perfect. You know, we have Epic's Cosmos, I think it is. We have, I think Mayo's putting something together like this. This is clearly a huge data set. And we've always talked about, you know, data is this is the gold rush of data. You know, data is the new oil, I guess, as they say. It specifically with regard to healthcare. If we could bring that data together, we can create more precise, determinations of what people have more. We can prescribe things more accurately. We can identify things more earlier, faster, as we just saw with COVID. So that's the promise of this whole thing. They use the word trust in here about 1 million times. So clearly they believe that is going to be the cornerstone, and it should be after the Ascension misstep. Let's call it a misstep earlier last year with Google. You know, they took a lot of heat because their people didn't know what they were doing. What are your first thoughts? I mean, that's one of my first thoughts on this is, do the patients know that their data just went into this de-identified thing? And because my data's in there. My data's in there. I didn't get any email. I mean, this is the first I'm hearing about it. I guess they think because it's going in de-identified, I'm okay with it. So that's the first thought I have. What are your thoughts?
Well, generally, from an altruistic point of view, I think it's great that we start looking at larger data sets, try to take out some of the bias that are in some data sets, and you know, it enables some great opportunities for research and to doing really a lot of public good. But it does come with a lot of big red flags. You talked about a few of them. And probably the primary one is, you know, did I agree? Is there some form that I already signed that said, yes, you can share all my information as long as it's de-identified? And that's something that we need to talk a lot more about, and to make sure that the appropriate safeguards are in place, because many will argue that there's no such thing as de-identified data. So
yes,
there's a way to break it back the other direction.
I've heard that. I've had data scientists sit with me and say, you give me the data set and give me enough time, I can de-identify it pretty. It depends what data elements you give them, but they're like, I'm pretty sure I can de-identify any data set that you give me.
Yeah, as opposed to the alternative approach, although it's a little bit more challenging and has its own issues, but that is, why not ask someone? Like, I would freely give my data if I knew that it was going to help the common good. So they would get my data so that people could avoid having cancer, as an example. I would freely give that data. And so, you know, it's one of those things where I think the more transparent you can be with the patient, the better, because it's the patient data. You've made that argument pretty clear in your podcasts previously, and I believe that to be the same. So I think you need to ask them straight out.
But I have made this before. Hey, one of the things you're going to learn in the podcast is you repeat yourself. And one of the reasons you repeat yourself is no one has listened to all 380 of my episodes. So you're like, okay. And you have new listeners coming on all the time who are like, yeah. This is one of my biggest arguments against the National Patient Identifier. And I understand, I get it is a good effort, right? We're going to bring all that data together. We're going to deliver it at the point of care, have the longitudinal patient record. I get why it's important, and it helps us at a time of mass vaccination and whatnot. I understand the argument for it, so I don't want the angry emails. I'm willing to have the conversation, but one of the primary reasons I'm against it is it changes the focus. The focus, if you're going with the National Patient Identifier, is The information is the property of the health system, and that's where you need to bring it all together. And what I'm telling people is, I don't want it to be brought together at the health system. I want it to be brought together at me. I'm the locus of information. I want to bring it to me. And so when all these guys say, hey, we're going to put all this information in, I said, great, that is a great endeavor. But here's what I want you to do. I want you to pass it through the patient first. Give it, all these health systems should give it to the patient in some app that I can look at and then say, all right, do you want to participate or not? Yes.
Yeah, I agree completely. That's what I was trying to articulate, and you did it with a much better, more clear example. But yeah, at the beginning and the end, it's got to be all about the patient. It's got to be patient-centric and allow them to see, oh, what information are you passing along? Okay, yes, I consent to that. And I think there's going to be more opting in than organizations think. And plus, it's just the absolute right thing to do.
Yeah, I think they're afraid that I'm not going to give it to my health system. I'm going to give it to Amazon or somebody else. And we already are. We're giving it to Apple, right? I mean, a bunch of us are. It's interesting. Yeah. You know what? I want to talk a little bit about Optum. So you teed up a story from Becker's. Why don't you talk a little bit about it, and then we'll go from there.
Yeah, because I just think when I think about digital transformation and from a provider-centric point of view and from a hospital point of view, when I read announcements about how big Optum, it's not just Optum, it's all the payers, how large they're getting in terms of primary care, they now represent the largest primary care base in this country. So Optum specifically has about 55,000 providers, going to add another 10,000 by the end of the year. So it used to be the way the ecosystem works, right, is you have a hospital and they attract a medical staff, and that medical staff is largely PCPs, who then refer to their specialists, who then bring patients to the hospital. That's sort of the ecosystem in a very generic sense. Well, think about the fact that all of your PCPs now are being disintermediated. They are being taken away. There's no longer this sense of loyalty necessarily to a hospital, but the affinity becomes to your employer naturally. So in this case, it might be Optum, and they have all these 1,500 clinics and growing. So what does that mean for the hospitals and their future to sort of control patient flow? And and it's not being done in secret. And then if you take it to the next step, so what the payers are also doing is they're doing virtual health. So the lead commercial in the Dallas-Fort Worth market from the Blues is telemedicine. So I'm thinking to myself, if I'm a provider in Dallas-Fort Worth, and this is all over the country, wow, they have more PCPs than I do, and they're doing telehealth visits. That means those patients aren't coming to my practice or to my docs that are affiliated with my hospital, and they're doing remote patient monitoring, and they're starting to do hospital at home. What's left for me? And I don't know that I've seen a lot of reaction yet by providers. And so that's really why I thought it was a good item for discussion. And what does it mean from a health IT perspective? If you're a CIO or a CDO at one of these health systems or hospitals, and your primary care base is being taken away, and why is that happening? And what can you do to stop that flow?
That's a great question. And it's not only Optum. And those numbers did surprise me when you shared them, 55,000 and 10,000 more physicians this year. We're going to see the same thing from Walmart. I've talked about that a bunch of times. CVS is the next one. And, Walmart for their part is getting into insurance. CVS bought into insurance. I guess, I'm not sure if Aetna's the controlling entity or CVS is the controlling entity. It's the two very large companies coming together. Everybody's trying to disintermediate the patient from the health system. And that's going to be a significant financial problem coming up for the health systems. So if you and I, so let's assume we just became CEOs. What would we do here? I think the first thing is, look, we already have a significant base of doctors in our market. How do we get them out in the community? How do we make sure we shore up our primary care physicians and make them as convenient as possible to access? Not in the old medical office buildings, but in locations where they're very accessible, including the digital routes, right? Yeah. It's accessibility, it's convenience, it's after hours access. We have a majority of that information. We have the leg up still, probably still today, we still have the leg up. if we start to make moves? If you're the CEO, what are some things you're doing?
Yeah, so I think it does come down to two broad areas. One is the patient experience that you're alluding to, and the other is the clinician experience. So what I'm understanding from some of my friends that are in this PCP mix with companies like Optum is their lifestyle is much better. So they are given, the equivalent salary with, now they're part of a for-profit company and incentives that come with that. And their lifestyle is better. So they're given finite hours in which they work, as opposed to just kind of an open-ended expectation. So I would do everything I can to ensure a great quality of life for my clinicians, that they would want to be part of the hospital and the health system, that they would have this affinity for working together to serving the community. So that would be number one. So like I said, it could be lifestyle related, like work hours. It could be having the right digital tools so they don't have to go in 7 different systems, that there's one platform that they might work with. So that's one thing. And then the other one, like you were talking about, Bill, is the whole patient experience. So we are going to have office hours in the evening. I remember how hard it was. I know you're a longtime CIO as well, having those discussions with medical staffs, like, no, we don't work, Wednesday evenings. Well, there's a way to do it and still have quality of life, right? It doesn't mean that they're working all day Wednesday and Wednesday evening, right? You have shifts and things like that. So there's a lot of things that you can do to make it a better experience for the patient, because you're right. You've got retail coming in, you got the payers we just talked about, you got retail. It's very convenient. You just walk in. Or a lot of them with their apps, for telehealth, they can press a button and talk to someone right away. And I don't think we're there yet on the provider side, the hospital side, making it that convenient. So that's what I would stress as CEO. I'd make sure my clinicians were all happy, had a good lifestyle, had all the digital tools they required. And then of course, all about the patient experience and patient engagement.
Yeah, because the patients really do follow the physician. If the physician goes from one group to the next, they'll figure out a way to go to that physician, won't they?
Yeah, absolutely. That's the key relationship. That's the trusted relationship. Trust has eroded in so many different verticals. You've seen the reports, especially politicians probably at the bottom. And the one that has been maintained is nurses and doctors have always had this high trust. And so I would just leverage that trust and really just, make sure that my clinicians felt like their job had meaning, their work had meaning, that they had ability to influence the organization, and that they had the digital tools, like we mentioned, to ensure, quality of life.
So you and I are going to close this with 3 stories which are related, and we're going to talk telehealth. We're going to talk remote patient monitoring, because that's what you're doing with Health Next. But before we get there, you shared an interesting story about the next generation of physicians and their training. Why don't you tee that one up for us?
Yeah, this has been really interesting for me. So my wife, who you might see her pictures in the background, she's getting her DNP, so her doctor of nurse practitioner. She's been a long time nurse. She's been a nurse, like, if I told you how many years, she might be mad at me, but she's been a nurse for like 30 years. And she's really digitally capable. And in fact, she led Epic implementations at her particular hospital in a big health system. So she went from bedside nursing into tech for about 5 years, led Epic implementation, represented, basically that hospital. She was like the liaison to IT for multiple years, and then went back to bedside nursing. And then the last couple of years, she's really been focused on getting her master's and her DNP. So I'm always asking, because I'm always curious, like, what are you learning? What are you learning? And so there's some journal articles now that are out there about what they are learning. And it's kind of scary, maybe because it just takes many, many years, but for modern digital practice to be folded into the clinician training. So this is clinician training for both doctors and nurses. And you would think, right, that they're learning all the digital tools, that they're learning remote patient monitoring, that they're learning about virtual care, but they're not. And so, when my wife was picking her dissertation, I was like, pick virtual care, pick digital medicine, because that is the future, and you'll be set, you'll be the expert with your doctorate. And her advisors kind of poo-pooed the idea. And I think one of the reasons why is because they didn't know anything about it. Right. So anyways, I think it's going to become more mainstream in our education. It just takes many, many years, almost like healthcare, bench to bedside. Similarly, I guess, in the educational side.
Yeah, the abstract says, that this is a perspective piece, seeks to highlight areas of concern related to a subset of areas of the digital health environment and provide potential educational pathways to prepare students. And the two of the things that they highlight is rapid technology development and a generational shift that's going on. The rapid technology development, you and I can appreciate. I mean, we've been CIOs during a time of just amazing change. I mean, you mentioned one earlier. We used to have to convince people to take the computer, the server out of their department and move it to a data center. Right. I mean, think about it. We used to have, anyway, they were scattered to and fro. Well, all these things, and this is now as powerful as most of the servers we installed back in 1990 or whatever. And so I was pointing to my phone for those people who aren't watching. But the generational shift is something that I thought was very interesting because they say this in the abstract. The digital natives are upon us. Although this article postulates these students who may be starting postdoctoral curriculums or other health sciences are inclined to be digital natives in accepting the use of technology in their lives, they are not necessarily well-versed on how to use it. The expectation for this generation to anticipate the use of technology may be beyond what their professors can envision in patient care. So you have that aspect of their professors can't really envision what's going to be next, but they also slide this little slight in on that generation saying, yeah, they've used it since they were born, but they don't really, they don't have the vision for what it can do either. They're just users of the technology. That's an interesting perspective. I don't know if I agree.
Yeah, it's interesting too, because I had this opportunity to help write the first, I think it's the first textbook that's really aimed at this problem for medical school. And it's probably going to be released sometime this year, I imagine, but I just wrote one of the chapters. And so I had to do a lot of empirical research. So this wasn't sort of my opinion, but what the research shows out there. And they really are lagging quite a bit, which then impacts us from a health IT leadership point of view, because even your digital natives that are coming on your medical staff now, they've finished residency, they're not necessarily super adept at all the medical tools. They are at the consumer tools, but at the medical tools, because they're professors, there's just a lag. That's the only way to describe it. So I think it's still going to take another 5-10 years before it all becomes mainstream and they're actually having courses, right? Their coursework should be on digital with digital tools. And you know how long it took the EMR to get studied. It took it a long time to get studied in medical school. So I think we're seeing the same sort of lag, but there's hope. It's changing. It just takes a little while. But the point is, people should just be aware of the fact that just because it's a digital native and generation of a different generation, they're not necessarily going to come in ready to practice with digital tools.
All right, so we're getting into your wheelhouse here, and that is remote patient monitoring. And so one of the articles is remote patient monitoring goes mainstream and healthcare transformation follows. The next one is doctors' virtual visits jumped 5,600% during COVID. This is actually about Canadian healthcare, but still, those are generally the numbers we heard in the States as well. It jumped dramatically. And then I highlighted a report that shows vast improvement in state telehealth reimbursement policies. And there's just a ton of information in that. Let's start with remote patient monitoring. So it highlights the tailwinds that are lifting the plane, and it identifies some of the headwinds. Talk a little bit about what we're seeing in remote patient monitoring these days.
Yeah, and I think, Bill, all these topics, again, that we're going to cover here pretty rapidly are really important for healthcare IT professionals to really understand, because we have to lead. It goes back to what we talked about earlier with the CDO and CIOs. We have to lead, and I know you've written there's been some articles out there about CIOs becoming key leaders, not just operational leaders, but more strategic, which is something we've always desired. Some have done it, most haven't. And here's really an opportunity to lead the strategy in the organization, obviously, along with your clinician counterparts. So yeah, with RPM, so we did see the big bump in telemed. I think it's come down, depending who you study, to about 20% or so. Some are still higher, some are a little bit lower, but I think 20% is obviously an empirical number that's been researched. And RPM has taken off as well, not as much because the use cases aren't quite as strong yet for RPM, but it's something definitely to keep your eye on. RPM meaning remote patient monitoring. So especially with COVID, So instead of filling up all your beds with COVID patients, many progressive institutions found if you were pretty low risk, they could send you home with a RPM kit. Maybe it's a pulse ox temperature reading, and they would review it on a daily basis and make sure you were okay. Very popular, simple use case. But even better use cases are for acute care conditions like maybe CHF and congestive heart failure. But anyways, those sort of acute care conditions are really prime. But I really think that you're going to see this shift. That's just the beginning. So while the penetration isn't the same as it is with a televisit, a visual visit, it's going to start creeping up and essentially, I believe, go past that because of hospital at home. And one thing is you've seen with the government recently announced, they're allowing certain organizations that met certain criteria to experiment and get paid for it in hospital at home. So they're testing the waters right now. And we've seen this before with CMS. They test the waters, they make some adjustments, and then pretty soon it goes mainstream. And I think that's really mainstream. I think one of the articles that we talked about was out of Denver, Humana maybe, in Denver, or maybe some other markets, Louisville, yep, where they are really offering this type of service. So it is hospital at home. It's daily visits, it's daily encounters, but with the appropriate technology. And so far, the early results are that the patients and families are happier because no one wants to be in a hospital. The financials on it can be up to 50% less cost, and the clinical outcomes appear to be the same or better. We actually did this for several years with maybe about 1,500, 2,000 patients where I came from and had that same sort of experience. So I think you're starting to see it build up. RPM is a key component of that, but that's why I think it's really relevant for healthcare IT leaders to have this on your radar and have a plan, partnering with your clinicians and other leaders and making sure that your organization takes advantage of this, because I believe that in the future that hospital care as we know it will be only for the very, very sick, high acuity surgical patients, high acuity patients that need an ICU. But other than that, patients will convalesce at home. Yeah.
My gosh, you gave me so many directions. Well, we have overhyped this in the past. We are guilty of overhyping this in the past, of just, remote patient monitoring, hospital at home. We got out over our skis and said it was going to be there. But now what you have is, it feels to me like a race for the home. Like, more services, more things going on. And it's being led by, it really is being led by whoever's taking risk, right? So you mentioned Humana is going after that. And there are health systems that have risk-based contracts, and they'll do this because it is a lower cost of care to do it out of the home than it is to do it in the facility. And so if you get good at this, you can actually drive some costs out of the system and still get reimbursed at rates that make sense. There's a lot of they talk about the tailwinds. Patient habits changed during COVID. Physician habits changed during COVID. EMR integration is way down the road for a lot of health systems. I realize I shouldn't speak so broadly there. There's still some health systems that are implementing their EMRs and whatnot, but workflows are there. Reimbursement is starting to catch up. And then the technology is there, right? So we didn't even hit on the fact that, my gosh, you can't open social media or something without seeing an announcement of some new device that somebody's funding, and we saw the Livongo deal and how much they were able to sell for and whatnot. So there's a race of money, minds, and talent running after the technology to really perfect this. And then you're starting to see some things sort of coalesce around this, not the least of which is this is one of the areas that competitors see as the opportunity to get in between, right? If I can go right into the home, either through televisits or physical visits, and then direct the care, I've now, again, disintermediated the health system.
Yeah, and this goes back to our earlier part of our conversation. If you don't take action, and I know there's always that sort of fear or governor that we don't want to get too far out ahead, but if we don't do something and take some risks, we are going to stop one day and look and say, where are our patients? We're going to keep, what we're going to keep doing is budget cuts. Yeah, we're going to keep, take another 10% out, take another 20% out. Why? Because the volumes are way down, revenue is way down, because the care is now being done by the payers. It's now being done by retail, And, the other category, there's a bunch of other categories, but the other category is digital first companies, digital only companies that do some of these things, and concierge medicine. And pretty soon there's not going to be anything left. So that's why even if it's an experiment or a demonstration project, as CMS would call it, I would get something going in my health system and start working it and seeing what happens, because otherwise you're going to be caught flat-footed. And I don't know that there's going to be time to pivot and catch up.
All right, Ed, let's get a little free consulting here from the Health Next, whatever your title is. I'm not sure what your title is. Let's just call you a CIO for now. So how does a health system wade into RPM, right? Everybody has a little bit of this going, don't they, at this point? Is it just a matter of expanding it? What is it?
Yeah, so my official title, I'm Chief Digital Officer for Tech Mahindra Health Life Sciences. And in the United States, a lot of people would know us more as HCI Group, but we're part of Tech Mahindra Health and Life Sciences. So here's what's going on with most health systems is they're all interested in RPM, but I would say only 10 to 15% are actually doing RPM. So there's high levels of interest. So because of COVID and the amazing televideo response that happened, and as you know, for some organizations, it went as high as 80% of all visits were virtual there for a while, sunk back, as we mentioned, to 20%. Now they saw the success of that, and now they're thinking, oh, we should probably move into RPM. And again, they're smart leaders out there, and they're reading things and seeing what competitors are doing or planning on doing. And so their initial foray is usually pretty low risk, and COVID's a really good example because it doesn't require a huge amount of technology, and it's pretty simple from an end user or patient point of view on how to operate these things. So that's what I would recommend. Start with something. It could be COVID. It could be a small demonstration project, maybe for CHF patients. When I was at the clinic, we had to develop for our areas sort of a vision statement, or broad, some people call them BHAGs, big, hairy, audacious goals. And for IT, and I led digital and IT, it was 50% of our visits would be virtual, outpatient visits would be virtual, and as a regular thing, not a COVID thing, this was pre-COVID, and 25% of our inpatient days were at home. So that's what we were shooting for. So you got to put up some sort of goal and objective. And so for us, that was pretty big, hairy, audacious goal. Think about that, 25%, apples to apples comparison. You would start treating those patients at home. So that would mean early discharge for some, and it would be no admissions for others. And that's what we were working towards. So you have to start someplace. You get the vision, then you take a demonstration project or two, find your clinicians that are really progressive, and there's those sort of clinicians everywhere. In fact, they're usually waiting on IT, and they get frustrated and go out and do their own thing. So find them, partner with them, and start doing things, and then collect the metrics. So it's really important, I believe, to be metric driven. So collect the metrics. Did you reduce length of stay? Did you reduce cost? What was the patient satisfaction like? So the more you can measure, the better evidence you have, and the better you can make your arguments for additional funding. Then you start getting funding, saying, look, we need to move this direction, and we have a very progressive unit here, and we're willing to do it. And that's what I've done pretty much my whole career, and I know you're the same way. If you wait, it's too late. You've got to take risks. You got to push the envelope. People may laugh. People laughed at me, Bill, I don't know if it was 15 years ago, because I was a big work from home person. And I took a lot of grief from HR, took a lot of grief from a lot of people about how work from home doesn't work. They ultimately let us do it. And then we were hit one time with a major blizzard, and then we were hit another time with a major oil spill outside our corporate headquarters. Just like a typical disaster scenario you make up, we actually had one of those happen. And lo and behold, pretty soon the rest of the organization started working from home as well. So you just got to push the envelope a little bit. And I think you'll find people out there, clinicians out there, that'll push with you. So that's some of the things. If I can recap really quick, is, you got to have the vision. You find collaborators, you push the envelope, you measure, then you go back and ask for permission.
Yep. You should always have a bunch of tiny projects going on, small projects for sure, something that you can almost fund out of your operating budget within IT and just keep them going. I know I'm not going to hit on the meat of what you just said. I love the physician. There's a physician that wants to partner with you, but can't wait any longer. And they say, and I remember just these stories I remember of people coming into my office saying, you wouldn't believe what what's his name did. I'm like, well, what'd he do? It's like, oh my gosh. he signed up for Dropbox. He's putting his images in Dropbox so he can share them with his patients. I'm like, all right, I want to have a meeting with him. It's like, oh, you're gonna slam him. I'm like, no, that's perfect. What he's trying to do is solve a problem and meet the needs of the consumer. And you know what? We're going to step in and we're going to partner with him and we're going to start doing that. And they're like, but he's not doing it right. I'm like, yeah, because we're not helping him. Let's go help him. Let's do it right.
Yeah. It reminds me too, we had a community at the clinic called Brain X. Had nothing to do with IT. Are you kidding me? IT would have squashed them. They were a bunch of smart physicians. They met after hours and they were talking about AI, machine learning, and they were actually getting data and they were building AI machine and capabilities and like actually impacting positively the quality of care. And so I heard about him. So I showed up at one of their meetings and it was the same sort of thing. It's like, oh my gosh, the CIO is here. He's going to shut this thing down. I was like, no, man, how do I officially become a member? And I did become a member. And the funny thing was they all expected me to be, super smart. And so at these meetings, they would talk the most complex things. Again, these are all highly trained clinicians who, for fun, do all this AI, machine learning, programming at night. And they would always turn to me after they'd have presentations every time that would just boggle your mind. And they'd turn to me and like, what do you think? And I'm like, I just didn't have any pearls of wisdom for them other than say, that is awesome, but that was my role. Sometimes your role is just to encourage that sort of innovation, encourage that sort of leadership, and partner with people, remove obstacles. I couldn't add any value from an intellectual point of view. They were way beyond me, but I could remove obstacles and give them safe guardrails and allow them to do amazing things that would save people's lives.
Yeah. Last thing here was, we're not going to get to cover it. We're already beyond our time, but it was a good article. I covered it in Today in Health IT. It's just the article on state reimbursement. And, you mentioned earlier, and so I just say that to tee up this question, which is, you said earlier, 50% of visits via telehealth and 25% of inpatient days at home. Is that right?
Yeah, perfect.
So that requires a business model change, right? And this is the thing we keep talking about CIOs stepping into those business model changes. Most CIOs don't want to wade in there. They're like, well, that's not the business model. We're not ready to go there. Instead of saying, I think this is the future. Let's encourage this conversation. Like, I think we can do this with technology. And if we can do it with technology, I think somebody else can do it with technology. So, at what point do we start to see business models change? And at what point are we a part of those conversations? And did you guys have those conversations?
Yeah, absolutely. And then that's what we're talking about when we talk about the CDO. And why are CDOs coming from other industries? And it kind of I'm glad because we need to learn from other industries. At the same time, I'm like, come on, because if you want to be the CDO, they shouldn't have to get someone from outside because you can do it. And so that's one of these areas where you have to lead. You have to be a business person. You have to be a clinical person. So don't be afraid. Don't say, oh, I'm just IT, I'm operations. Well, then I wouldn't hire you as a CDO if that's the way you felt. So you got to be bold and take risks, even if it means you lose your job. So what? If you're good, you'll get picked up somewhere else. So you got to be bold. That's the worst thing, right? I know this isn't what you asked, but the worst thing is someone who just becomes assimilated. Like they're bold, they get hired, they're so excited, and then they get pushed back, and they decide to play it safe. And that's why healthcare is so far behind, because so many of us have played it safe over the years. So it's time for bold new leadership, whether it's outside or inside. So to answer your question, yes, of course. And so we really had to work through it. So I led it, I pushed our way through it, and we changed it. So what it was, I'll give you two really good examples. One was how physicians were compensated. So I can't get into the specifics, to reveal sort of the magic sauce of where I came from, but there was a definite way that physicians were compensated. Productivity was analyzed carefully. So suddenly you're doing telemedicine visits, which at the time were not on parity in terms of reimbursement with an in-person visit. So how do you make that change? So what do? You get with the chief of staff, you get with the CFO, you start laying out the arguments and why this is the future and why we have to go this way and why we have to make accommodations in that productivity formula. And that's what ended up happening. They made accommodations in the productivity formula so that you were not penalized for doing a telemedicine visit. That was number one. The second one, which I was not successful with, but I bet if I had another run at it today, I would be. And that is, why do we have urgent care why do we have urgent care clinics when we have virtual care capabilities? Why do people go to virtual care? Okay, you go to the ED ideally because your artery is wide open and you need something quick, life-saving. That is good. Virtual care not going to help you very much there. But urgent care, why do you go to urgent care? Because it's less costly than ED care. It's usually less wait, a little bit more convenient, and there's more locations typically. But that's exactly what virtual care is for. So I took that on, Bill. I wasn't successful, but I took it on. I said, look, we want to go to 50% of outpatient visits being virtual, but yet we're advertising and pushing our urgent care centers. We don't need urgent care centers. It's brick and mortar. It costs a lot of money to run those brick and mortar centers. And we can do about probably 95%, because the argument is you can do about 85% of what happens in ED, you can do it virtually, or what happens in an outpatient setting. So in urgent care, it's probably like 90%. Okay, so let's argue you're a clinician, I'm not. Let's just say it's 80%. Okay, whatever that number is, a high amount of the reasons you would go to urgent care can be done virtually. So don't have urgent care centers. Let people go to the ED that need to go to the ED, handle everything else with virtual care. I did not win that one because why? Urgent care makes a lot of money.
Yeah. Well, okay. Hey, let me close on this question, which is, you've done podcasts now for a while. And this is consulting for Bill. You're going to give me some free consulting here. What's the most challenging thing of doing a podcast?
Well, I've only hosted 6 or 7. So are you asking as a host or as a?
Well, no, you used to do that other series that you did as well.
Yeah,
so.
Yeah. Okay. Is preparing, it takes a lot. People don't realize it. I know you do. It takes a lot to prepare. My episodes are short, maybe 25 minutes, and it takes a lot of preparation to do it right. So anyone can sort of wing it. But if you want to have that professional level quality, giving out great information like you do, it takes a lot of preparation. So it's hard to fit that in my regular job, to add that in. It takes a little bit of effort.
Yeah, I did. And I would say that's the number one thing that people don't realize. People are starting podcasts all the time. And I have a whole thing of show notes right in front of me that I prepared. And it took me an hour and a half or so. Plus you and I both read about 6 or 7 articles to go along with that. And so even though it sounded like a spontaneous conversation, that's part of the gift, right? It's figuring out how to make it feel like a spontaneous conversation, even though you prepared for almost 2 hours for a conversation.
Yeah, and that's why, and I hope you keep this in the show, that what I'm about to say, Bill, that's why I'm so thankful for you and all the work that you do and you put into the show. I know you do it because you're passionate about it, and I also know that obviously you make a living from it. But what you're really doing is investing in the next generation of leaders. I know that's part of your statement as well, your passion. And what a gift to have someone else put in all that investment and then to bring in the most important things and talk about it. And then you always have fascinating guests, because it would be boring, right? As great as Bill is, or great as Ed or Drex is, or Sue is, we get boring after a while. But you bring in these other guests with these different perspectives that are clinicians and digital people and all that kind of stuff. And it just adds so much value. So if I were a CIO today, I'd almost make it mandatory that you're listening to all these things from Health IT from Bill Russell, because it makes you a better employee. It makes you a better leader. And so I'm really thankful. And you know this because I've told you this privately, but you're the main thing on my runs. I run a lot. I listen to podcasts. I keep up to date thanks to you. I don't have time to do it otherwise. And I really appreciate all that you do for the industry.
Well, I appreciate that. I'm going to start leaving like codes in the show for you to pick up on. Anyway, it'll be a lot of fun. Ed, thanks for stopping by. I appreciate it. Where can they find your podcast? What's Digital Voices?
Yeah, Digital Voices. It's spelled like DGTL, try to be like hip. DGTL Voices. And we're on everything, I imagine, Spotify and Apple Podcasts and whatnot. But yeah, thanks again for having me.
Oh, yeah. It's fantastic. And by the way, you were the #2 runner-up in referrals for the Cliff Notes program, which is why you're here, just so you know.
I'm going to be #1 next time, because I didn't blow it up as much as I had intended to, but I have shared it with all of our leaders of our organization. And it's funny, I'll tell you one quick story. We have a new person that came from outside of healthcare, And that's the one thing I told him. I said, listen, follow Bill Russell. You'll catch up on healthcare. And now if you were to meet him, he's only been in healthcare about 6 months. You would never, you would think he's been in healthcare for 6 years. And a lot of that has to do with you because he's listened to all your stuff.
Yeah, well, I appreciate your support. Frank Neidham, for those of you who are wondering, who was the top referral? It was Frank Neidham from VMware, and he has agreed to come on the Newsday show. We haven't scheduled it yet, but he has agreed to come on the Newsday show, so I'm looking forward to that. He's a great guy, and appreciate his support. He's with VMware. All right, that's all for this week. If you know of someone that might benefit from our channel, please forward them a note. They can subscribe on our website, thisweekhealth.com, or wherever you listen to podcasts. Apple, Google, Overcast, Spotify, Stitcher, probably some other places that I'm not even familiar with. We want to thank our channel sponsors who are investing in our vision to develop the next generation of health IT leaders: VMware, Hillrom, Starbridge Advisors, Aruba Networks, and McAfee. Thanks for listening. That's all for now.